Welcome to this explainer. Today, we're unpacking a really critical and honestly often misunderstood medical condition that silently derails the careers and the long-term health of countless female athletes. We're talking about the female athlete triad, and together we're going to look closely at how to recognize its dangerous domino effect before it's too late. So, you got to ask yourself, what exactly happens when a healthy, highly motivated athlete just starts running on empty? I mean, literally running with nothing left in the tank. It's a pretty serious question. Throughout this explainer, we'll be following a real-world case study of a 15-year-old varsity cross-country runner whose body suddenly and seemingly inexplicably just started breaking down. Her story is absolutely the perfect lens for us to understand this syndrome. But before we get deep into the science, let's just explicitly bust a really pervasive, really dangerous sports myth right out of the gate. This whole idea of the less I weigh, the better I perform. Look, the reality found in the data: losing lean muscle and essential body fat doesn't make you faster. It actually destroys your athletic performance and your long-term health. Being under an ideal body weight means you simply do not have the fuel to compete, or even just to heal from a tough workout. To help us understand how to combat this, here's our roadmap for today. First, defining the triad. 2, its 3 interconnected components. 3, causes and risk factors. 4, clinical manifestations. And finally, number 5, physical therapy management. Section 1, defining the triad, a 15-year-old's case. Okay, let's dive into this. Let's return to our case study to see what this actually looks like in the real world. Picture this, a super dedicated 15-year-old varsity cross-country runner. She comes into the clinic wearing a walking boot, complaining of severe left foot pain. We're talking stress fractures in her metatarsals. But when you look a little closer at her history, these major red flags start popping up. She had a history of bilateral tibial stress fractures, basically shin splints that got so bad they progressed to broken bones. And she was experiencing amenorrhea, that's completely missed menstrual periods. Essentially, she was caught in this biological trap of unexplained recurring bone injuries. At the very heart of her condition is something called low energy availability, or LEA. By definition, this is the dietary energy left in your body after your exercise is completed. So think of it as your calories in minus your exercise calories out. When that number drops too low, it's just insufficient to support normal physiological functions. It's exactly like an engine running out of gas. To survive, the body is literally forced to shut down non-essential systems, prioritizing basic day-to-day survival over things like building strong bones and reproduction. Section 2, 3 interconnected components, the triad spectrum. And this brilliantly illustrates how one failing system inherently threatens the others. The research shows this syndrome as a sliding scale, or a spectrum. See on the top right, in that green triangle? That's optimal health. You've got optimal energy availability, eumenorrhea, which is just a medical term for normal menstruation, and optimal bone health. But as an athlete's energy availability drops, they slide right down that spectrum toward the red triangle: low energy availability, functional hypothalamic amenorrhea, and ultimately osteoporosis. You can really think of this as a biological domino effect. In a totally healthy state, adequate fuel leads to regular menses, which in turn promotes strong bones, because estrogen naturally inhibits bone resorption. But when that first domino falls, when there's just low energy, it knocks over the reproductive domino right next to it, causing menstrual dysfunction. And without those reproductive hormones, the skeletal domino falls right behind it, leading to decreased bone mineral density. That is exactly why our 15-year-old runner kept getting stress fractures. Her bones were literally weakening from the inside out. Section 3, causes and risk factors. What drives the triad? So how does an athlete get to that point? Well, the risk factors for the triad fall into a few clear categories. For bone density, obviously a history of stress fractures or any recurrent, non-healing injuries is a massive warning sign. For low energy, we're looking at things like early sport-specific training, severe overtraining, or just immense outside pressure to lose weight. But we absolutely must consider psychosocial factors too, things like inappropriate coaching, extreme perfectionism, or a history of depression and anxiety. In fact, our 15-year-old case study patient also struggled with generalized anxiety disorder and OCD, which heavily compounded her risk. It's all connected. So, the crucial point the sources emphasize here is addressing another incredibly harmful myth. You hear this a lot, the idea that it's somehow okay or even normal to stop menstruating during intense training. Well, the medical consensus is absolute on this. It is not okay. If a female athlete hasn't had a period for 3 months or more, she is in a state of severe energy imbalance, and she needs to be evaluated by a physician immediately. You have to treat the menstrual cycle as a vital sign.
Section 4, Clinical Manifestations, Spotting the Red Flags.
Okay, we have to clearly differentiate between normal athletic wear and tear and actual triad red flags before irreversible damage is done. General muscle soreness, feeling super fatigued after a long, grueling race, that is totally normal. We've all been there. But bilateral tibial stress fractures, extreme drops in BMI, noticeable anxiety around food, or completely avoiding whole food groups, those are massive clinical manifestations of a system in deep distress. Our runner's recurring fractures weren't just bad luck. They were her body screaming for fuel. Now, what's really interesting about this slide is what the data reveals when low energy availability is driven intentionally by a restrictive eating disorder. It's fascinating, but also pretty alarming. The body essentially goes into this deep survival mode. Symptoms include things like cold intolerance, intense fatigue, and dizziness. But the physical findings can be as severe as bradycardia, which is a dangerously slowed heart rate, orthostatic hypotension, and even something called lanugo. That's the growth of fine, downy hair all over the body as it desperately tries to keep itself warm due to a complete lack of subcutaneous fat. Section 5, Physical Therapy Management, the Road to Recovery. All right, let's focus on solutions and how we actually guide athletes back to health and back to their sports safely. The most important thing to understand here is that recovery is a marathon, not a sprint. Take a look at how the three components of the triad recover at vastly different rates. Energy status, that can improve in a matter of days or weeks with proper fueling. Menstrual status, however, takes months of sustained energy balance just to restore those reproductive hormones. And bone mineral density, that can literally take years to fully rebuild. Patience is absolutely paramount here. Let's move to and see how this builds into a highly structured physical therapy plan. For our 15-year-old runner, she couldn't just lace up and jump straight back onto the track. Step 1 involved a simple walking program combined with core strengthening. Step 2 introduced a carefully managed plyometrics progression to gently simulate the loading forces of running. Step 3 was passing a strict readiness to run protocol. And only then, only if she passed, could she begin Step 4, which is a very conservative return to run progression. And let me tell you, that readiness to run testing protocol is incredibly rigorous. To even begin running again, the athlete had to successfully complete a 1-minute wall sit, a 1-minute plank, 30 step-ups onto a 6-inch box, 30 double leg jumps in place, and 2 sets of 10 single leg squats. And here is the major catch. Any pain or any compensatory movement that indicated weakness meant she had failed the attempt and just wasn't ready yet. The body has to prove without a doubt that it can handle the load. Ultimately, though, physical therapy is really just one piece of a much larger puzzle. Effectively treating the female athlete triad requires a united, multidisciplinary team approach. You need a primary care or sports physician monitoring health markers. You need a physical therapist guiding the musculoskeletal rehab. A sports dietitian is crucial for ensuring proper energy intake, and often a mental health professional is needed to address any psychological barriers. And of course, coaches and parents, they must be supportive allies in the daily recovery process. Everyone has to be on the same page. Which leaves us with one final, pretty provocative question to ask ourselves. Are we prioritizing the scoreboard over the health of our athletes? The female athlete triad is entirely preventable, but it requires coaches, parents, and athletes to fundamentally rethink our sports culture. We need to monitor these critical risk factors closely, and we have to prioritize long-term well-being over short-term wins. Thank you so much for joining me for this explainer. Now let's take this knowledge and use it to keep our athletes healthy, strong, and properly fueled.